Welcome to Medical Specialists Associates Pain Medicine Educational Series. This topic is safe opioid prescribing in the modern era, evidence-based guidelines and practices. Introduction. Today, we'll discuss safe opioid prescribing practices, focusing on the latest evidence-based guidelines. This topic is crucial for managing pain effectively while minimizing the risks associated with opioid use. What are opioids? Opioids are a class of medications used to manage moderate to severe pain. Common opioids include oxycodone, hydrocodone, morphine, and fentanyl. These drugs work by binding to specific receptors in the brain and spinal cord, reducing the perception of pain. When are opioids beneficial? Opioids can be beneficial for severe acute pain, such as pain following surgery or a traumatic injury. Palliative care, for patients with severe chronic pain due to cancer or terminal illnesses. Certain chronic non-cancer pain conditions, where other treatments have failed, such as severe osteoarthritis, rheumatoid arthritis, peripheral neuropathy, severe back pain due to degenerative changes or spinal stenosis, post-herpetic neuralgia, and chronic pancreatitis. Conditions and justifications. 1. Severe osteoarthritis and rheumatoid arthritis. Opioids may be used when other treatments such as NSAIDs, physical therapy, or disease-modifying anti-rheumatic drugs, DMARDs, are insufficient. 2. Peripheral neuropathy. When other medications like anticonvulsants or antidepressants do not provide adequate pain relief. 3. Severe back pain, degenerative changes, or spinal stenosis, considered when other interventions such as physical therapy, NSAIDs, or injections fail to alleviate pain. 4. Post-herpetic neuralgia. For severe cases where other treatments, including anticonvulsants and topical agents, do not suffice. 5. Chronic pancreatitis. Opioids are considered when enzyme supplements and other pain management strategies are ineffective. When are opioids not appropriate? Long-term opioid use is generally not appropriate for chronic headaches, including migraines. Opioids can lead to medication overuse headaches and have limited efficacy in chronic headache disorders. Fibromyalgia. Opioids are not recommended due to the lack of evidence for long-term benefit and the risk of dependency. Non-specific low back pain without a clear diagnosis. Limited evidence supports the efficacy of opioids in non-specific low back pain, and the risk of adverse effects outweighs potential benefits. Pain associated with mental health conditions. The presence of mental health disorders, including depression and anxiety, can complicate opioid therapy and increase the risk of misuse. Pain in patients with a history of substance abuse. High risk of relapse and opioid misuse in this population. Alternative pain management strategies are preferred. Additional conditions and justifications. Chronic pelvic pain. Opioids are not first-line due to the potential for dependence and lack of evidence for long-term benefit. Irritable bowel syndrome, IBS. Opioids can exacerbate symptoms such as constipation and do not address the underlying condition. 3. Temporomandibular joint disorders, TMJ. Long-term opioid use is not recommended due to lack of efficacy and risk of addiction. Or endometriosis. Opioids do not address the underlying cause and carry significant risks with long-term use. 5. Functional abdominal pain syndromes. Opioids can worsen gastrointestinal motility and should be avoided. Safe opioid prescribing guidelines. 1. Initial assessment. Comprehensive evaluation. Conduct a thorough medical history, including a detailed pain assessment and screening for risk factors for opioid abuse. This includes understanding the patient's psychosocial situation and any history of substance use disorder. Diagnostic testing. Use diagnostic tools and tests to accurately diagnose the source of the pain. 2. Starting opioid therapy. Use only when necessary. Opioids should be considered only when non-opioid therapies have not been effective. Lowest effective dose. Start with the lowest effective dose of a short-acting opioid. Short duration. Prescribe opioids for the shortest duration necessary. For acute pain, a few days is often sufficient. Patient education. Educate patients about the potential risks and benefits of opioid therapy, including the risk of dependence and overdose. 3. Ongoing monitoring and follow-up. Regular follow-ups. Schedule regular follow-ups to assess pain relief, functional improvement, and any signs of misuse or side effects. PDMP checks. Utilize prescription drug monitoring programs, PDMPs, to monitor prescription histories and detect potential abuse or doctor shopping. Urine drug testing. Implement periodic urine drug testing to ensure compliance and detect any illicit drug use. Random pill counts. Conduct random pill counts to ensure that patients are taking their medications as prescribed and not diverting them. 4. Duration and dosage. All low dosage. Avoid increasing doses above 50 morphine milligram equivalents (MME) per day. While in some cases, increasing MMEs beyond 50 but no greater than 90 can be appropriate, it is crucial to follow the CDC guidelines to not increase opioids beyond 90 MME, except in cancer-related pain, palliative care, or hospice care. Why 50 mg and 90 mg limits? A 50 mg limit. The CDC guidelines recommend not exceeding 50 MME per day due to the significantly increased risk of overdose and death at higher dosages. Studies have shown that patients on dosages above 50 MME per day have twice the risk of overdose compared to those on lower doses. 2 or 90 mg limit. The limit of 90 mg per day is recommended to further minimize risks while balancing the need for pain control. Research indicates that increasing opioid dosages above 90 MME per day does not significantly improve pain relief or function, but markedly increases the risk of adverse outcomes, including opioid use disorder and overdose. Scientific justifications. Overdose risk. Higher opioid dosages are strongly associated with an increased risk of opioid overdose, with a dose-response relationship indicating that higher doses correlate with higher risks. Lack of additional benefit. Evidence suggests that doses above 90 MME do not provide additional pain relief, but increase the risk of harm. Respiratory depression. Higher doses of opioids significantly increase the risk of life-threatening respiratory depression. Avoid dangerous combinations. No benzodiazepines. Avoid prescribing opioids with benzodiazepines whenever possible due to the increased risk of severe respiratory depression and overdose. Buprenorphine as a safer opioid option. 1. Introduction to buprenorphine. Buprenorphine is a partial opioid agonist that is increasingly used for pain management due to its unique pharmacological profile. It binds to the same receptors as other opioids, but produces a less intense effect, reducing the risk of abuse and overdose. 2. Mechanism of action. Buprenorphine acts on the mu-opioid receptors, MOR, as a partial agonist, and on kappa-opioid receptors, KOR, as an antagonist. This dual action contributes to its analgesic effects while minimizing the risk of respiratory depression and other side effects common with full opioid agonists. 3. Benefits for pain management. Efficacy in chronic pain. Studies have shown that buprenorphine is effective in managing various types of chronic pain, including neuropathic pain, osteoarthritis, and lower back pain. Ceiling effect. Buprenorphine has a ceiling effect on respiratory depression, which means that beyond a certain dose, the risk of respiratory depression does not increase significantly, making it safer than other opioids. Lower risk of tolerance. Buprenorphine has a lower potential for developing tolerance compared to full opioid agonists, which helps maintain its effectiveness over long-term use. 4. Safety profile. Reduced overdose risk. The ceiling effect on respiratory depression significantly reduces the risk of fatal overdose with buprenorphine compared to full opioid agonists. Lower abuse potential. Buprenorphine's partial agonist properties and its high affinity for opioid receptors make it less likely to be abused compared to other opioids. It can also displace other opioids from the receptors, which can be beneficial in preventing misuse. Ling et al., 1998. Management of opioid dependence. Buprenorphine is also used in medication-assisted treatment (MAT) for opioid dependence, which highlights its safety and efficacy in managing opioid use disorders. 5. Clinical evidence. Chronic pain management. Research has demonstrated that buprenorphine is effective for chronic pain management with a favorable safety profile. For instance, a study in Pain Physician showed that transdermal buprenorphine provided significant pain relief in patients with chronic lower back pain, cancer pain. Buprenorphine has been found to be effective in managing cancer-related pain, with fewer side effects compared to morphine and other opioids. Opioid treatment agreements. On purpose of opioid contracts. Opioid treatment agreements, or contracts, are formal agreements between the patient and the healthcare provider. These contracts outline the responsibilities of both parties to ensure the safe use of opioid medications. 2. Key components of the agreement. Patient responsibilities. Patients agree to take medications exactly as prescribed, not to share or sell their medications, and to store them safely. Provider responsibilities. Providers agree to prescribe opioids only when necessary, to monitor the patient's use through regular follow-ups and urine drug testing, and to provide alternative pain management options when appropriate. Consequences of non-compliance. The contract outlines the consequences if the patient does not adhere to the agreement, such as discontinuation of opioid therapy. Importance of adherence. Following the opioid treatment agreement is crucial for maintaining trust and ensuring the safe and effective use of opioid medications. Non-compliance can lead to serious consequences, including the termination of opioid therapy and potential legal ramifications. Using one pharmacy for medications. Rationale. Using a single pharmacy for all opioid prescriptions helps to prevent doctor shopping and reduces the risk of medication errors. It also allows the pharmacist to monitor the patient's medication use more effectively. 2. Benefits. Enhanced monitoring. The pharmacist can monitor for potential drug interactions and ensure that the patient is taking medications as prescribed. Better communication. Improved communication between the healthcare provider and the pharmacist ensures coordinated care and early identification of any issues. Formation of a COAT committee. Purpose. The Chronic Opioid Analgesic Therapy COAT Committee is a multidisciplinary team established to oversee opioid prescribing practices within a clinic or healthcare system. The committee aims to ensure safe and effective opioid use while minimizing the risk of abuse and adverse outcomes. 2. Functions. Case reviews. The committee reviews complex cases to provide guidance on opioid prescribing, ensuring adherence to guidelines and best practices. Policy development. The COAT committee develops and updates opioid prescribing policies to reflect the latest evidence and regulatory requirements. Education and training. The committee provides education and training for healthcare providers on safe opioid prescribing practices and emerging trends in pain management. All benefits. Enhanced safety. The committee's oversight helps to identify and address potential risks associated with opioid therapy, ensuring patient safety. Consistency. Standardized policies and procedures promote consistent and evidence-based opioid prescribing practices across the healthcare system. Conclusion. Opioids can be an important part of pain management, but their use must be carefully managed to avoid misuse and complications. By following these guidelines, physicians aim to provide effective pain relief while minimizing the risks associated with opioid therapy. If you have any questions or concerns about your pain management plan, please discuss them with your healthcare provider.